Thank you so much. I'm not Dr. Tooba Ali. I'm Bilal. I am just a messenger for this abstract on behalf of Dr. Tooba. So I hope I'm not asked many questions regarding this study. So Tooba does not have any financial disclosure. She's a second-year resident at our department and has led this work for IGRT for prostate cancer. During the presentation, I would go over the background, objective, methodology, results, and the conclusion of the finding. Is it better now? So we know that prostate is the second most malignant tumor among males internationally, and radiotherapy has an established role. And this is one of the tumor where the expertise and technology has advanced a long way more than any other sites, and therefore IGRT and cone beam CT are nowadays the standard modality for ensuring safety for the patient as well as delivering an adequate dose to the patient. There has been proven to be a relationship with the prostate volume and the rectum volume as well as the position of the prostate gland. The prostate displacement, as evidenced in the literature, could be more than 5 millimeter with rectal filling of up to 30 to 50 centimeter cube, and majority of the prostate movement is in the anterior direction. So the paper regarding increased risk of biochemical and local failure in patients with distended rectum on planning CT scan demonstrated that with greater than or equal to more than 16 centimeter cube of the volume and having a rectal diameter in the cross-section anatomy area of greater than 11.2 centimeter cube may result in the displacement of more than 19 centimeter cube with excessive prostatic motion during radiotherapy causing target underdosing. And therefore, rectal distension and higher risk disease are going to be the independent risk factor for biochemical failures. Regarding the role of image-guided radiation therapy in prostatic cancer in a systematic review who compared IGRT versus non-IGRT, and there were 3-year progression-free, 3-year benefit on biochemical failure-free survival as well as the PSA and specific relapse-free survival. So since this is a radiation oncology meeting, image as the rectum anterior posterior diameter changes, it impacts the position of the prostate and well as the doses to the surrounding structure, which include overdose to the bladder as well as to the rectum. So talking about the flow of treatment planning, the patient undergoes bowel preparation, protocol explanation by the doctor, and prescription for milk of magnesia if required, and according to the need of the patient, following which the patient undergoes tip simulation, followed by planning scan before doing a pilot scan before going through a planning CT scan, and then if there is any discrepancy or the volume of the rectum or the diameter of the rectum is not adequate, the patient is educated and a repeat imaging is done. Following the adequate imaging, the patient undergoes target volume delineation, followed by treatment planning involving the oncologist as well as the physicist. On the day of treatment, pre-treatment, patient undergoes patient positioning for with digitally reconstructed radiograph and cone beam CT. Setup corrections are done. Matching of the bladder filling and rectal diameter is done with the planning scan, and adequate optimization is done as it may be required before proceeding with the treatment. So this is the prescription or instruction provided to the patient. So the objective of the study was to correlate the compliance of bowel preparation with interfractional rectal diameter variation during image-guided radiation therapy for prostate cancer, and to assess the radiation-induced acute toxicity through RTOG rectal toxicity scale. So patients receiving definitive adjuvant or salvage radiation for prostate cancer were to be included. However, we only have those patients with intact prostate here. CBCT was done in bowel preparation tutoring were done for all the patients. Patients having metastatic disease or inflammatory bowel disease were not included in the study. It was a prospective observational study. And after obtaining approvals from ethical review committee, the study was proceeded. So we had sample size overall calculation done with the WHO calculator, which came out to be 97 scans, including CBCT and planning CT scan and non-probability type convenience. Show here the interim results. So compliance was measured on evaluation in weekly follow-up clinics according to the definition. The data was collected for planning CT scan, daily CBCT CT scan. Rectal volume was controlled as the diameter measured on upper and lower part of the CTV slices, and rectal volume was measured for each cone beam CT and correlated with the planning CT scan. And you can see in this picture a planning scan and a cone beam CT scan. So the DVH were reviewed on each of the rectal diameter on the CBCT as well as on the cone beam CT. The data was analyzed using SPSS version 23 for descriptive statistical analysis. Continuous variables and ordinal type variables were to be analyzed in their respective way. So RTOG definition, which everyone is familiar with. So we report 60 CBCTs analyzed for 3 patients having a median age of 52 years and mean PSA level upfront of 39 patients. So one of the 3 patients had to undergo a repeat CT scan. Here we can see that the compliance to the milk of magnesia declined from 84% at the time of planning scan to less than 30% or around 30% over week 7. However, the dietary compliance remained stable throughout the planning CT scan and the course of treatment in our study. So the rectal volume varied from 70 to 138 centimeter cube. The mean rectal diameter at superior end of CTV was 4.2 centimeter, and at the inferior end it was 3.26 centimeter. Mean rectal dose on planning CT scan versus CBCTs also showed differences in significant p-value, which was less than 0.05. Highest proportion of compliance to bowel preparation protocol was reported for patients number 3 who had been found to be completely compliant during the protocol treatment. In fact, you can see in the chart that the rectal diameter was in fact lower as compared to the planning CT scan in this particular patient number 3. Here you can see the DVHs of the rectum on planning scan and CBCT for the 3 patients that we have. The rectal toxicity during the initial weeks of treatment was 34% of patients experienced grade 1 toxicity, subsequently escalated to 52%. Grade 2 toxicity and leading to discontinuation of milk of magnesia in this particular patient. The least reported toxicity profile was for patient complying to anti-flatulence diet who had observed only grade 1 toxicity, and that was during the week 3 treatment. So the last slide showing that our research findings indicate that adherence to bowel preparation significantly influences the reduction of rectal diameter variation and rectal toxicity. However, the use of milk of magnesia results in diarrhea, thereby having a possibility of increasing the overall treatment-related toxicity. So thankful to all the team. Tooba wants to appreciate the members of the staff, therapists, medical physicists, and nursing, and also the patients. So this is a picture from our Aligned Health Day, which was celebrated approximately 3 weeks ago in Karachi. Thank you.